Good afternoon. Welcome back. A big part of making life better for people with Parkinson's is taking care of the people who care for them. Each person with Parkinson's is unique, and so is each caregiver. Caregivers have an enormous, often underappreciated job. They suffer from burnout, depression, and anxiety. A Parkinson's disease diagnosis and all the care coordination that comes with it can be very stressful. Many caregivers spend a large amount of their time providing care, and in many ways it is a full-time job. You have met each one of our expert panelists earlier today, so without further ado, to my far right, Dr. Jori Fleisher, is a movement disorder fellowship-trained neurologist with a special interest in understanding the needs of individuals and families with advanced Parkinson's disease and related disorders. Jori, what are some of the misconceptions and myths about medications used for Parkinson's disease?
Thanks so much, Caryn, and thank you all for sticking it out to the end. You should be so proud of yourselves. This is a long day. So I don't think of myself as an angry person, but I get really angry when I hear of my people, my PD people, being mistreated, and a lot of it comes from myths and misconceptions that are out there and just widely spread, not just from the internet, but from doctors and other folks, not maliciously. But there is an idea out there that there's some magical 5-year cliff in Parkinson's. You have 5 good years and then. There's no 5-year cliff. There is no scientific basis to that. There is no biological basis. There is no ticking clock after which you self-destruct at 5 years with Parkinson's. This came from old studies that looked at people who've been on large doses of medicines for 5 years and found after 5 years, X% of people developed this complication. And that, number one, has been disproven a little bit, especially as we have new medications and we use them differently, but has been sort of interpreted and played telephone with to folks out in the community saying, well, you only have 5 good years, so get your affairs in order, and then, it's all downhill from there. Nothing magical happens at 5 years. I have people who have had Parkinson's for 30 or 35 years. So I just want to sort of counterbalance that, because if you're approaching that 5-year mark and you've heard that about your loved one, I don't want you counting down the days or waiting and watching and having anxiety about something magical or something horrible that's going to happen then. I think one of the other ones that actually it has truth to it, but it gets misinterpreted, is protein. So there's a lot online, good old Uncle Google, that talks about protein and levodopa and the interactions. And what I see as someone who focuses on more advanced Parkinson's disease is people who have heard this, and so they've cut out protein. And they've lost weight unintentionally. And it's not the good kind of weight that we all want to lose. They've lost muscle mass. And so if your loved one with Parkinson's is losing weight unintentionally, when they fall, if they fall, they're much more likely to break something, to wind up in the hospital, and to start this bad cycle, right? And so, yes, protein can interact with certain medications. It's not a problem for everyone. It's not a problem for most people until much later in the disease, and there's certain ways we can know, is it happening or not? But I want you to take away that it is okay to have protein. It is necessary to have protein. And I tell you this in the spirit of collaborative caregiving because you are the front lines. You are the ones who are managing medications a lot of the time. You're looking online. You're trying to find what is the next best thing. What else can I be doing for my loved one? There's a new medication. Should he be on that? Should she be taking this? Right? So I think knowing out there that some of what you read online is not true and that there's a lot of nuance and you should be empowered to ask. And don't just believe what you read. Go find someone who knows and ask them the questions.
Thank you. Dr. Angela Roberts has been a speech-language pathologist for 23 years, and Angela specializes in working with people with neurodegenerative diseases, not just Parkinson's, but also those with Alzheimer's. We were having dinner last night, and in listening to what she had to say, I realized that I myself continually fall into bad behavior when it comes to discussions with my husband who has Parkinson's. And though I know better, and though I know what I should not say, I continually find myself going down the wrong path. I don't know if any of you share in this. Good, I'm not alone. It does make me feel a little better. So my question for Angela, which now I know more than I can benefit from, is how do I get back on the right road? How do I stop this from happening and these counterproductive behaviors?
So thanks, Caryn. I'm going to pivot this just a little bit to say we, in part, have done this to you, right? So if you as caregivers feel badly that you're on path, off path, on path, off path, it is in part because sometimes we as healthcare professionals set a very unrealistic expectation. And my colleagues, some of my colleagues and I on the speech language pathology side, some of us agree and don't agree on this, but the fact is that we tell you that if you go to an intervention and you do everything that you're supposed to do, you will walk away and your speech will be better and your communication will be better. And then when you get home and it is not, you feel like it's your fault. And we have set up these unrealistic expectations that effects last forever and that the path is always straight after we try to fix it. And that just really is not true. And so my encouragement is that you think about being patient with yourselves, that you encourage your partners who have Parkinson's disease to also be patient with themselves, that this is a journey that requires flexibility, adaptability, that the strategies even that I told you about today, some of them work better for some people than they do for others. One of the differences in the treatment program that we designed in my lab was to be able to customize the strategies that we taught to families. And more than that, that we gave them the flexibility to adapt those strategies as they needed to over time. And it's one of the ways that the research that we do differs. Because that adaptability and that flexibility is absolutely key. No one strategy is going to work every day of the week to improve communication. And even the strategies that I gave you today, when you go home to use them, they might work one day, might not work the next, they'll work again the next day. And so the trick here is to be persistent, to be patient, to work through and continue to practice and try and not to give up. Because one of the biggest barriers that I find is that you try something that doesn't work, and because we've set you up to believe it should always work every time, you then walk away and abandon it, and that's not what we want. I'm telling you that the variability is normal. The fact that things aren't going to work every time is normal. And the fact that sometimes you're still going to have to walk away and go, I've got to come back to this later, is normal. But that shouldn't mean that you walk away from it. So be patient, be persistent, be resilient. And I think that's probably the biggest trick to how you get yourself back on path, because you're really never off path. You just take a little curve, right? And I would argue that you're never off path. And I think if you remember that it's just a curve in the road, then you're able to get yourself back there and back centered much more quickly.
Thank you. We will take questions when everyone has had a chance to speak. Dr. Sheila Silver, as you all heard this morning, is a board-certified clinical sexologist in private practice. So I heard what you had to say, but undefended communication, you lost me.
Okay. So undefended communication, I could actually give a day-long workshop on, and I think all of us could improve our communication. So many times when we're in a conversation, especially a conversation where we may be in different opinions about things, or we're trying to cajole our partner to see things our way, we don't do good listening. We're focused on what we want to convey, but we're actually not listening to what they're saying very well. We're getting ready to say our next thing, and we're not listening to what they're saying. So one of my tips around undefended communication is to not think about what you want to say next, but to focus on what are they saying, first of all. And it kind of overlaps a lot with what Angela was talking about in terms of making sure you're understanding what they're saying and making sure they're understanding what you're saying. So whether you call it active listening or mirroring or paraphrasing, I think it can be really helpful when somebody says, I'm concerned that we never have sex, or we have no intimacy in our life, or whatever, however something comes up in terms of emotional communication or sexual communication, that you say, so I think what I'm hearing you say is you're feeling like we're not being sexual, or you're wanting to be closer to me. Tell me more about that. Instead of immediately responding in a defensive way, just saying, give me some more information. Tell me more about how that is for you, so that you can get as much information as you can from that person that you're talking to. And then you have a moment to say, okay, I really am wanting you to understand what I'm saying. So you share in a vulnerable way, and you invite them to repeat as best they can what they heard. Now, obviously, if you're dealing with somebody who has PD and is fairly cognitively impaired, this is harder. But assuming you're talking about somebody who's capable of having a conversation, you want to make sure they're understanding you and you're understanding them. So listening, answering in a way that's undefended, and using I statements. This is what I'm experiencing. This is how I'm feeling. Not you're doing this and you're doing that, but talking about your own experience as best you can, and talking about also how you see yourself contributing to the problem, owning your part of the dance. Whatever's happening, both of you have a part in it. So owning your part of it and saying, I get that I avoid too. I'm on my phone, I'm watching TV, I'm doing this, and I get that I'm kind of avoiding our time together in the evenings. So I'm prepared and willing to commit to not doing that as much. And maybe we can have a time at 8:30, we put away our phones and we turn off our computers and we turn off the TV and we hang out and we play a game together. We sit on the couch and we talk, or we lay on our bed with our clothes on and just hold each other, or whatever you want to do together. But I think you owning your part of the problem opens the door for them to be willing to do that as well. That's a little window into that.
Thank you. Next we have, hold on, Miss Elaine Book, right here. Elaine has worked in the field of social work for over 30 years with a focus on, well, it said with a focus on the geriatric population, but that's wrong. I went to listen to Elaine's breakout session. I have little grandchildren, 5 of them. So my question to Elaine was, what do parents or grandparents say when little ones, or not even so little ones, but just children, ask questions like, how come Daddy or how come Grandpa sleeps all the time? Why didn't he think my joke is funny? Why didn't he laugh? Just the questions that children slowly begin to observe about people with Parkinson's who might not be responding the way they think they should respond.
Thank you. So I think I might even just take it the step further back, because before we can kind of explain about the symptoms of Parkinson's disease or how it presents in anybody, we always kind of have to start with, well, have you told the children about the diagnosis? And, you know, for those of you who have not told the children in your world about the diagnosis, you might be nervous about that. You might be nervous about how to do it and when to do it. But people sometimes tend to think that the Parkinson's disease isn't impacting children in their lives, and are often kind of concerned about presenting them with too much information, that it might be scary for them. However, really breaking that silence is actually really helpful to the children and can decrease any stress or anxiety that they may be having about some of the symptoms that they're witnessing. Children, as much as they can be a little bit self-absorbed, I have a couple of them myself, they are also quite perceptive, quite sensitive, and quite intuitive, and may already be picking up on that something is different, something is not the same as it was before, and can actually be worried that it's something far more scary, more concerning than a true diagnosis of Parkinson's disease. So really, secrecy can be quite harmful as compared to telling the truth about any kind of health issue, because when we give children accurate, age and stage appropriate information about something, it really does decrease their the sense of unknown, and that's important. And so really, regardless of the age or relationship of children in your lives, I certainly do encourage people to share the diagnosis and perhaps share the process of how the diagnosis was made, provide age and stage information about it. Consider talking about what your best understanding is of what's going to happen. And, I also encourage people that I work with to practice. You need to get comfortable with this conversation, with the language, with the words that you want to use, so that you can present this information in a positive, a hopeful, a calm way, because really how you present the conversation is what they're going to take away from it. Not unlike when the person with Parkinson's received the diagnosis. If that diagnosis was delivered in a calm, hopeful, factual way versus some people have received a diagnosis in less than that, I think it's really impactful. So the best ways really to support the children in your lives and to address, some of those symptoms is really checking in with yourself and your attitude and making sure you're in a good place to provide that authentic, honest, positive perspective. You want to use words that are easy to understand, not euphemisms. Use the word Parkinson's disease. You might want to use shaking instead of tremor, or slowness instead of bradykinesia, but things that, depending on the age and stage of the kids that are in your lives, using accurate words. And then timing. Timing is everything. So, timing for you when you're good to talk, timing for them when it's good for them to listen.
Thank you. And last, we have Jessica Shurer. Did I pronounce that right, Jessica?
I don't know, because I have no idea how to pronounce my own.
Okay, we're good.
My mother-in-law says shore like a seashore, and she does the little hand thing. Very good. Sure.
For Jessica, one of the things that I wanted to ask her, based on all the information that we received today, as a care partner, I was sitting here thinking, how do I synthesize it? And so what I have to ask of Jessica is, if there's only one thing that we can retain, just one bit of advice that she would give to caregivers, what would that piece of advice be?
Can I give two?
2 or 3, or as many as you'd like.
What I really like, for me, like a big takeaway for today, this concept of collaborative caregiving that's been this running theme of today, is that can mean something different for every single person. But what it kind of boils down to is that someone could build their interdisciplinary health care team. They can build their support system, tap into resources, that care does not have to be a one-way flow, and that it can be a true partnership between you and a loved one with Parkinson's. And what that says to me, that I hope that everyone takes away from this, if you take away one thing, is that you are not alone in this journey. You do not have to be alone in this journey. You mentioned at the beginning of this that burnout, depression, anxiety, guilt are very common with care partners. I think that's something that we as a foundation, as healthcare professionals, we talk about, but that in daily life, it's really hard when you're trying to just survive the day, getting your loved one through the day, getting yourself through the day, you're in survival mode. It's really hard to step aside saying, you know, am I experiencing depression right now? Or you know that you're overwhelmed and you want to pull your hair out, but it doesn't really matter because you just got to plug through. And so I think also checking in with yourself once in a while. I really like during the caregiver panel, I believe it was Dean that shared that once a month they have we're gonna, on the 19th specifically, maybe everyone will do this on the 19th, getting together with your loved one with Parkinson's, being like, what's working, what could we improve? But you could do that you could have that conversation with yourself too. It's good to have with your partner to keep that open line of communication, but once in a while say to yourself, how am I doing? Is this sustainable in the long run? What have I learned so far? And what are some ways what are some things we can perhaps change that will make life a little bit easier for both of us? How am I coping overall? And then it's also all well and good for so many of us as professionals or even family members to say, make sure you're taking care of yourself. But that's going to look different for every person, realistically. And also, what does that mean for you and your daily life? So defining for yourself, what would self-care look like for me? And what steps can I take? And I think, to me, part of self-care is finding times of joy, finding gifts despite a really not fun situation. But the big thing that I hear from my care partners and that I hope that we can impart on you is that all of you, you're doing the best that you can. You probably did not anticipate being in this scenario or having this role or having a loved one with Parkinson's. The person with Parkinson's is also doing the best that he or she can given these cards that were dealt. But somehow, whether you're new to this journey or you've been on it for 25 plus years, you've somehow figured it out. You have brought strengths and skills to this experience, and you've probably gained a lot of strengths and skills along the way. And I want you to be kind to yourself through that and recognize your own strengths. You're very resilient people. So just remind yourself of that every once in a while.
Thank you. Questions? Don't be shy.
I'm new to this experience, and what a wonderful day it was in every aspect. I'm very bitter going to the front presenter about the misinformation. We had a horror story in Texas with a neurologist that said, my wife has Parkinson's, see you in 6 months, here's the medicine. Oh, don't go to a support group. Thank God we found the Muhammad Ali and the foundations, and having experiences like this. I guess my question is, what can I do, what can we do, what can the Parkinson's Foundation do to somewhat control, I mean, all due respect to anybody that's a neurologist and it becomes a doctor, but Parkinson's is unique, and to dismiss it the way it's being dismissed today, I mean, literally, still in these times, what can be done?
Thank you for that question. I think that's an amazing question. I think being here and getting all the information that you're getting, and now you are going back to your community and you're already an advocate, but being able to serve as an advocate, anyone that you hear of, just in your own daily lives, anyone that you hear of that has Parkinson's, sharing some of what you've learned, sharing the resources, this works for me, this doesn't work for me, I think that's wonderful on sort of an individual basis. Maybe it's helpful, and so I will be the first person to say there are a lot of neurologists out there who are terrible with Parkinson's disease. Neurology used to be the specialty that was billed as diagnose and adios, or we can diagnose everything and treat nothing. And I went into it specifically because I think that's wrong. So there are a lot of neurologists out there who essentially, let's say that they've been in practice for 20 years or 30 years. They may be trying their very best to take care of their folks with Parkinson's disease. What you have to know is neurology training means college and then 4 years of medical school and then a year of internship in internal medicine and 3 years of neurology training. And for general neurologists, that's what they have. And for neurology residency, you spend about 80 to 90% of your time in the inpatient side, taking care of people with stroke and seizures and MS flares and encephalitis and infections and all kinds of horrible, terrible things that acutely come to the hospital. Thank God, we very rarely on the inpatient side have folks with Parkinson's disease. As a movement disorder specialist, that is my goal. I do not want my people in the hospital, right? But what that means is our trainees today, but even more so people from, way back when, their exposure to Parkinson's might have been maybe 10 minutes in a lecture during med school, maybe someone, a patient or two during their rotations in neurology, if they had one, and not every medical school makes you rotate in neurology, let alone Parkinson's. And then maybe they took care of a patient or two with Parkinson's in the hospital as a resident. That might have been 20 or 30 years ago. Maybe they remember what was state of the art back then, and maybe they don't. But they are trying to keep up with everything in brain tumors and stroke and seizures and multiple sclerosis and ALS and Parkinson's. And so it shouldn't be surprising to us that they're often not the most knowledgeable and the most on top of things. Does that mean that I don't get righteously indignant and drop some choice words when I hear stories like that because it happens all the time? Absolutely not. The system has to be better. So there's a lot of work underway to fund more movement disorders fellowships, to train more neurologists to become movement disorder specialists. Part of the problem with that is making sure that our folks, our trainees, don't just see people with Parkinson's in the hospital. Because when people with Parkinson's are in the hospital, they look terrible. They're there for some reason, whatever it is, but often if you go into a hospital with Parkinson's, you come in with one problem, you leave with 5, right? We know that medicines get messed up, that all kinds of other things happen. So trying to get college students, trying to get younger folks engaged and involved, I think, with Parkinson's, and to see people with Parkinson's as people with Parkinson's first, right? To see them as people first and not to see them in the inpatient setting, not to see them when they're sick, but to come into the clinic and see my people who are doing great, right? Not all my people are doing great, but a lot of my people are doing better, right? And so we need to get through to younger generations. We need to fund better programs to educate people, but I think also taking all the resources that are out there and serving as your own advocate. It shouldn't have to be on you. It shouldn't, but it is right now to a large extent. So taking all that information that's out there and bringing it back to your providers and being like, hey, there's this new medicine. Have you heard about it? You should. Can we talk about this next time? Right? And if they're not listening to you, maybe finding someone new, right? I think having that relationship, this is not a one-off deal, right? You're going to be seeing them for a long time. So finding someone who gets you and is receptive, I think, is really important.
Also, I'm sorry?
I think I want to expand, your comments are perfect, and I want to expand those to healthcare more broadly, not just neurologist. And so there's a bit of a microenvironment here in the Phoenix area where you have the Muhammad Ali Center, and it provides spectacular care. But please remember that for people living in more rural regions, there are physical therapists, speech-language pathologists, occupational therapists who may have never seen anyone with Parkinson's disease, who may not have even have had a case study on it when they were in school. And this is particularly problematic in speech-language pathology and in occupational therapy. So it is incredibly important that you educate providers. We spend a lot of time wanting to empower care partners. I completely agree. Is it fair? No. But again, you're not facing this battle alone either, because there are resources at the Parkinson's Foundation and others that you can just say, hey, go read this booklet. It'll help you as much as it helps me. And so I think this broad kind of piece of being an advocate for your loved one with Parkinson's disease, we absolutely know that referral rates to allied health are abysmal. They're abysmal even in some of our centers of excellence. They're better for some disciplines than others, but this provides us a need to do this more broad education, not just with neurologists, but everyone, dietitians, social workers, anyone who is touching your loved one with Parkinson's disease may need your support to get them the right information so they can provide good care. Because they may not be providing care just because they don't know what to do, or they're not aware of the options.
In listening to things today, it's clear where there are centers of excellence, there is some coordination and collaborative kinds of things that go on, but there aren't that many of them. And even in larger cities, many of us are dealing with disjointed care provisions when we get them. They're not interrelated, they're not Parkinson's designed, they're a referral for something that's a one-shot kind of thing, and then it's done. How do you get that collaboration?
Anyone?
I think one thing you can start with is letting everyone on the team know that they're on a team, because they don't know it yet, right? They didn't ask to be on the team. Maybe they don't want to be on the team, but you're putting them on the team, right? So tell the primary care doctor, my loved one is seeing such and such neurologist, and they sent him to such and such physical therapist and to speech therapy, and we're also seeing a social worker. The PCP, the primary care doctor, may not do anything about that, but you've let them know that there are other folks, and maybe that tickles something to them to say, oh, well, actually, wait, you know what? There is this physical therapy for Parkinson's. Are they doing that? Are they doing the right one? Maybe I should look into this. You know, let the urologist know if you're seeing someone for urinary retention or frequency, let them know, give their name to the primary and vice versa. Let everyone on the team at least know that those things are happening. It may not magically make everyone coalesce and rah-rah, but I think that's the first step.
People need a microphone.
What do you do when you have your primary care doctor, you go to a specialist and you say, I have my primary care doctor, I am looking for a specialist in this field, and the new doctor you're talking to says, I don't want to be on your team, basically. You know, you have one doctor that will give you prescriptions, you go to another doctor in a different field, and they'll say, oh no, you shouldn't be taking those pills, you need to be taking these. Which doctor do you go with, or what do you do in a situation like that?
I will say I'm biased, but I would always go with the doctor who plays nicely in the sandbox with others. It's not just me. It should never just be me. My family loves to ask me about their rashes and their GI problems, and I don't do that. My husband's OBGYN. We're not useful at parties for the most part, but that doesn't stop people from asking, right? And so I think, you know, find the doctor, find the team that is okay with and recognizes that they don't know everything, and that this is a multi-system, multi-dimensional disease that affects not just the person with the label, but the family, and that can at least appreciate that. And if they don't know the right person to send you to, they're willing to ask or call the Parkinson Foundation helpline, like all of these things. But someone who says, no, don't go to them, or someone who says, don't get a second opinion, you absolutely need to get a second opinion.
We have time for, there we have one over there.
So we always stress that if our loved ones are in the hospital, it's important that they get their medication every time on time. And we know that. We take it to the hospital, and when they're being taken care of, we tell them, my mom needs her medication. She needs it on time. It's time. And you tell this to the staff, and they give you, it's coming, or we have to wait for this test, or we have to wait for this doctor. What can we do as patients to work with that team, but to really push to get the medication on time? You've notified them, but you're not getting action.
I want to monopolize. Sorry. Aware and Care Kit. Aware and Care Kit, Parkinson Foundation has put together this very snazzy swag bag for Parkinson's, right? And it's this little black bag. It's free. You can order them, right? But in it, it has a medication list that I would encourage you, don't just write it once. Everything changes all the time. Keep that list updated. You keep that in the bag. If there are medicines that it's uncommon for the hospital to have, right? Regular old Cinemet and things like that, common to have. Fancier medicines, newer medicines, Nuplazid, Rytari, some of the fancy schmancy stuff, if you're on that, put it in the bag and bring it with you, like a hospital go bag if you're in labor, right? You bring it with you, but in there are tear-off sheets that says, if I have confusion, safe, not safe. If I have this, safe, not safe. And it has lots of information about why the meds need to be given on time every time. Will this prevent the meds from being delayed? No, not all of the time, but it will empower you, and it literally, you have a prop, right? You have a prop, and that tells the person in front of you, this is a problem enough that someone made a prop for this, right? Like, this is a big enough deal that they've got a bag and they've got swag and they have like papers about this. I guess I should listen, right? I mean, it's got a logo. It looks really good. It looks really important because it is. So I would take all of those. I tell my folks, rip off that tear-off pad. I will get you a new one if you go through it in one visit, right? Give it to dietary. Give it to the orderly who walks in the room. Tape it above the bed. Make a sign, that says, my name is so-and-so, and I need my meds on time, right? I take my whatever at 7, at 11, at this, and, harass the crap out of people. Honestly, because, what's going to happen otherwise is your loved one doesn't get their meds on time. They need physical therapy in the hospital to get them up and moving. Physical therapy comes, but they haven't eaten and they haven't taken their meds. Yep. So they can't get up and work with physical therapy. Now you're in the hospital for another few days, and you're at risk of infection and all kinds of other things, and it all just snowballs. So it would be in the hospital's best interest to just listen to you.
Thank you. We have a few more questions, and we have 5 minutes.
One thing that I added to the swag bag, and this was when my husband had DBS surgery at Banner. I had to do that. I found it necessary to do this. But I got a letter from the Muhammad Ali doctor saying exactly that he needs his medications on time every time. And again, this was for DBS surgery at Manor. And, in my mind, they should have known that. They deal with Parkinson's all the time. But I added that to my swag bag along with instructions from the support from Muhammad Ali Center.
Thank you.
Sorry, yeah.
My question, and you just answered, Jori, but I have a comment to add to it and want some feedback. When my husband was last in the hospital in mid-June, I had the black bag. I was very vocal. I was very proactive. They weren't doing it. I just had medicine that I brought, and I gave it to him. And I would apologize later. And that's my statement, that if they aren't going to do it, take care of it yourself.
I cannot endorse that.
All right.
But I can, because I did the exact same thing. And what I discovered, and for those of you that live locally, my husband is a patient at the Mayo Clinic as well as the Muhammad Ali Center. And at Mayo, they're called Mayonized. And the nurses follow very strict orders, but they're not the orders that you give them. It's not the advice that you give them. So what I found I had to do, because of the constant change and shifts of the RNs, is go to the director of nursing and basically say, this is what I'm going to do unless you take action. They still didn't take action, so I did the same thing. We have 2 questions back there.
This is a little bit off the subject, but it gets to a subject that's kind of dear to my heart. I'm concerned that sometimes the focus we often have in caring for our loved ones with Parkinson's is cure, cure, cure. We're looking for this cure. And I have a friend who's a physician who said, in my lifetime, we're going to find a breakthrough. I would like to see, in the meantime, before the breakthrough comes, more focus upon palliative care, symptom control, because the suffering that goes on while we're waiting for this cure, while the person can't exercise, while the person has to have other procedures done, when the person can't even leave the house to have the rock, the boxing. Palliative care can really help us feel like there's hope and there's a chance for a quality of life that would otherwise not be possible.
Thank you so much for pointing that out, because actually that at our table at lunch, that's something that a couple of us were talking about, that I think it's so important with any disease, and diseases are diseases, it's dis-ease. Like, we don't ever want someone to feel uncomfortable and live with something that threatens quality of life and mortality, but that's what these do. And so would it be great to have a cure to take away Parkinson's and everything? Absolutely. Some people need to have that as a mindset, as a goal to give them this sense of hope. Like, there will be a cure and I just need to stick it out till then. But you're right, it's until then, and the truth is there's so much that's still not understood enough about what even causes Parkinson's that we have to figure that out first. Yes. Before we can even inch towards a cure. But you're living with it today, and I know I am biased because I don't work for the Parkinson's Foundation, but I've worked with the Parkinson's Foundation now for 6.5 years. I've so appreciated that is what PF focuses on. There are organizations that we need that have a primary focus on finding a cure and funding, I was just looking at the zeros. Oh, sorry, and funding research that will work towards a cure. But what goes hand in hand with that is organizations like the Parkinson's Foundation that are focusing on living well today and quality of life now.
And
so thank you.
So that's what I just wanted to add on to, because I think what you brought up was a really important point, which is, okay, well, while we're waiting, what are the things that we can do to really increase quality of life for the person with Parkinson's and for the caregivers as well? And that's what the palliative care approach is all about. And there's been a tremendous movement in palliative care and Parkinson's disease to really look at the idea, the concept that palliative care really starts at diagnosis. Now, that's a bit of a hard pill for some people to swallow, that they're going to become part of a palliative care team upon diagnosis. And so palliative care tends to be looked at kind of in the mid or later stages of Parkinson's disease. But again, ultimately, and you as caregivers can do this in your role at home, which is really just kind of looking at what are the the wishes, what are the values, what are the desires of the person with Parkinson's, and how can you make those things still happen? It's going to have to be adapted and accommodated, but what are the things that are really important and bring joy to every day, and getting really creative about making that happen. That's palliative care in the home. That's not medical palliative care, but that's palliative care in the home, and those are the things that you can do as caregivers.
And they're not mutually exclusive. Treating something from a life-prolonging standpoint and from an intervention rehab standpoint is not mutually exclusive from focusing on comfort and dignity and quality of life. They should go hand in hand from the day of diagnosis, and that's palliative care.
Annie.
Sorry.
That's okay. No, am I on? Yes, okay. I didn't want to cut you off because that's so important. And before I say anything else, I want to let everyone know that fabulous swag bag, the Aware and Care Kit, you all can get one of those absolutely free. All you have to do is call our helpline, 1-800-4PD-INFO or 473-4636. And let them know you want the Aware and Care Kit. We want to make sure everyone who is caring for someone with Parkinson's, everyone who has Parkinson's has access to that kit, and we do have it both in English and in Spanish. For our international listeners, it's a little more complicated, but if we hear from enough of you that you want it, then maybe we'll have better answers for you. All right, so thank you so much to our expert panel.